Welcome to this video on slit lamp examination. In this video we're going to show you a patient with 90D lens, and here you can see we're seeing the optic disc, and there's a shine over here around the disc, and this is signifying silicone oil in this patient. Here you can see there's a shine of the slit lamp bulb seen over here, and I'm going to tilt the lens side to side, and you can see these shining areas, bright areas where the oil is reflecting. This was a relative young patient, so you can see the shine much more clearly, but this is what you need to see. The cup to disc ratio is about 0.3 in this patient. So you have the slit. This is the patient's right eye, and you're going temporally. The patient actually had a retinal detachment secondary to multiple holes, and there were also a macular hole which seems to have opposed pretty nicely after silicone oil. The next thing we want to see is the periphery of the patient. This is the central area which we're trying to see. There is no scar of retinotomy, and this is the interesting area which we see over here. This is the buccal. This is important to recognize a buccal, and this is the area of the buccal which you need to see. This is a good buccal. The buccal height is wide, so this was a 7.5 mm buccal or 277 tire which has been sutured. So it is a 7.5 millimeter buccal which was there. And the next thing you want to see is, are the breaks on the buccal or not. So we go forward and let's see at the buccal. These are cryo marks which you see. Let me just highlight those cryo marks once they become clear. So I did cryo for those patients, and there is a residual area. So this is the area of cryo marks which you're seeing over here. So this is actually the break which you're seeing over here, and these are the cryo marks which you're seeing. Let me go make this run forward slightly, and let's see if we can see those marks over here. And this was the So you're seeing this area of the buccal, and this is the temporal area with flat retina on the buccal. Next we go down and ask the patient to look down, and here while you're looking down you can see the inferior meniscus of the oil. So this patient seems to have about an 80% fill of oil. Let me get a good look at this and I'll show you. This is the area of the silicone oil which we're seeing, and this is the area of buccal which we're seeing over here. And keep looking at this area of silicone oil inferior meniscus. So if I'm going to move this area of the silicone oil is more prominent over here, so you can easily see this area of silicone oil. This is actually the area of silicone oil. This is the end of the buccal which you're seeing. And these are cryo marks on the buccal. This was an area of resolving SRF which I saw over here. And you can see as I move the slit around, you will see cryo marks. The important thing to remember is, if you have a 80% fill of foil and the retina is attached on the buccal inferior to that, that means the retina will remain attached if you remove that silicone oil. Because if there's 80% fill and there is no detachment, that signifies that the inferior retina has attached. This is the nasal retina which is seen over here on the buccal. If the buccal is too tight, you will get radial folds on the buccal like this. So there are no radial folds on the buccal. So the buccal height is adequate, and it is, some people might say it's slightly moderate amount of buccal height. If you give too much of height, then you will get these radial folds which I'm telling you. And if you get too much of a buccal height, then sometimes the eye will obviously become myopic because of the high buccal, and sometimes it will compress on the vortex vein and it can produce anterior segment ischemia as well. So this is the nasal retina, which is seeing with the 90 diopter lens, or actually it was a superfield lens which I was using, and this is the superior area of the buccal. Interestingly, there was two areas or two small holes which are evident over here, which had escaped treatment with cryotherapy or laser treatment. So what I did was identify these holes and right away did laser using a superfield lens onto those breaks. So it's pretty simple to do that. But the good thing is once a break is on the buccal, even if you do it later on, it remains flat, and here you can easily see that area of the buccal. Looking from outside, you can see the patient is faking, and oil will produce some bit of cataract. Here you can see some bit of posterior subcapsular cataract opacities, which I'll show you. So if you see oil, sometimes you'll see those star-shaped opacities, but these are opacities due to the silicone oil. The other thing which we need to focus on is externally on the conjunctiva where the sutures are placed. So this is looking at the red reflex of the lens and identifying that thing. Then this was the right eye of the patient. It's important to identify where your sclerotomy marks are. Usually if it's the right eye, the infratemporal mark will be inferior to the insertion of the medial lateral rectus, and the superior will be above the lateral rectus, while the nasal sclerotomy will be above the medial rectus muscle. So if you take in hours, it'll be 7, 11, and 2 o'clock or 1 o'clock, depending on how you are doing surgery. The more near to the center of if you have your sclerotomy site at 10 o'clock, probably you will get more leverage. You can move your endolite or probes easily around, but if you're more superiorly, you will have difficulty maneuvering it superiorly. So that's why the more down you have, it's better off, but you don't go below the central meridian. So you just 10 o'clock is probably the ideal position to stay on that area. So this is the sclerotomy marks which have been closed with 6-0 Vicryl. This is the supro. Actually, thank you very much for watching.